Good afternoon. Thank you very much for introducing me. Dear participants, ladies and gentlemen, please bear with me for 15 minutes. I know that the difficulty you are going through it. I can see you are having a very difficult time opening your eyes. Yes, I know you need a cup of coffee, but bear with me for 15 minutes, please. Yes, as I told you in the morning about the MNH situation in Nepal, Nepal has one of the highest MMR in Southeast Asia. It's 281 per 100,000 births, and major causes are, as you know, is postpartum hemorrhage is 17% in 2009. 1998, it was 46%. And delivery by skilled birth attendance is still low, but it's increasing. It was 19% in 2006 and 36% in 2011. And uterotonic coverage is still very low. And retaining the SBAs is in remote areas is a very big problem. I would like to take you back to my, the title of my presentation is a pioneer in community-based distribution of misoprostol. So with pride I can tell you that Nepal has been very successful in distributing misoprostol through community-based programs. And how did we start the PPH, this pilot program? There was a meeting in 2004 in Bangkok. This was a misoprostol symposium. And in that meeting, Secretary of Health, Director General of Health, and many high-level directors attended that meeting. And in that workshop, Nepal committed to pilot misoprostol. Then we took this with the professional organizations, Safe Mothers Subcommittee, and we formed a technical advisory group, and Nepal Health Research Council approved the pilot, and it was piloted from 2005-06. In the pilot context, we always said that misoprostol is plan B. For us, the priority is to increase the skilled birth attendance, institutional deliveries through health facilities upgrades. Emphasis on AMTSL, active management third stage of labor at health facilities, and SBA in-service training. And we have this maternity scheme. We always encourage the pregnant women to come to the health facilities. And the misoprostol is distributed by the female community health volunteers for prevention of PPH at home birth within the broader community approaches at the 8th month. And this community service delivery system is done by FCHVS, which I discussed in the morning. At the 8th month, the FCHV gives the mother, pregnant women, 3 tablets of misoprostol and tells her to take it once the baby is born. And in that counseling also she emphasizes that she should go to a health facility to deliver the baby. But if she cannot go, then she should take this tablet once the baby is born, before the placenta is released. I won't be discussing on the key roles of FCHVS because I've already discussed this, and we had this discussion yesterday also. And this is basically they are birth preparedness, complication and readiness, danger signs and referrals, they do it, and distribute iron folate tablets, misoprostol, BPP, action cards, and family planning commodities. I'd like to discuss with you some of the results from the pilot that took in Banke district 2005 and 7. I see many people who have visited this Banke districts, and they know this. This is one of the findings of that pilot. The timing of the misoprostol use. Before the delivery of baby, none of them took the misoprostol tablet. After the delivery of the baby, before the delivery of placenta, 86% used it appropriately, and 14% took it after the delivery of both the baby and placenta. Asked why they did that, they said that the sequential was so fast that they could not they could not, the placenta came out so fast that they could not, they didn't have time to take that misoprostol in between. And discussing about the symptoms reported, we have this, those who used the misoprostol and those who did not use the misoprostol. Dizziness was more in the, who did not use the misoprostol. Shivering was more in the misoprostol group, but other symptoms, nausea, fever, loose motion, headache, was not significant in both, was significant in both groups were same. And uterine tonic coverage, if you see that, the baseline was around 10%, but at the end line you can see that oxytocin also has increased and the misoprostol has also increased. This shows that the oxytocin use has been increased. And if you see the use of skilled birth attendants, the baseline in 2005 was 11%, and first follow-up at 2007 was 17%, and second follow-up 2010, you can see that more and more people are coming to the institute deliveries, that is 49%. So this program, this misoprostol distribution has increased the skilled birth attendance. A conclusion from the pilot is that that significant increase in there is a significant increase, high coverage in government system with mobilization of female community health volunteers. Adverse effects were not a significant problem at all for this pilot, and misoprostol should be used with the force to increase the skilled birth attendance. And we have moved from the pilot to the expansion, expansion from the pilot. In 2010, we reconvened at Bangkok. There was a meeting where the Nepal team committed that there will be a national level expansion. And then in June 2010, Nepal approved the national level expansion, and misoprostol was approved for the national expansion. And 2010 July, we developed guidelines and implemented guidelines. Now misoprostol is scaled up throughout the country, but it's a phase-wise approach. And before we used to get misoprostol tablets from venture statistics. Now the government of Nepal is procuring misoprostol tablets. Current government of Nepal approach to PPH prevention, this is, you can see that for the prevention of PPH, active management of third stage of labor, use uterine drugs, oxytocin within the minutes after delivery of baby. Only trained health workers can do MTSL, cord control traction, and uterine massage. And for the community settings, use of uterine drugs, uterine drugs, misoprostol after the delivery of the baby. And this is the map of Nepal. This is in 2005, that was in one district. Then we expanded to several districts. Now it's expanded to more districts now. And currently we have in this many districts. Now we have plans to expand it to all the districts. Sorry. I'd like to discuss with you uterine coverage in selected program districts. You can see in most of the districts, misoprostol coverage has increased, but health facility and health worker delivery also has increased because of this misoprostol program. And conclusion is that urgent need to reduce the maternal mortality due to PPH. And we should do a realistic piloting under the MOHP, rapid move from pilot to scale up, consensus and support from all stakeholders, that is, we have this Nepal Society of Kindness for Scale Up. And Nepal is pioneer in successful in implementation of misoprostol and has been subject of global interest. And the challenges are distribution of misoprostol tablet, ensuring availability and transportation, and collection of reports from grassroots levels, and collection of unused tablets from the grassroots levels also is a challenge. Program expansion, coverage only in partner-supported districts so far, limiting the expansion in priority districts only, the remote districts. We have not been able to expand to those districts, and ensuring the quality of trainings to the FCHVs. This FCHV needs to be trained, and we have to ensure that this huge number of FCHVs, around 53,000, should be trained to distribute misoprostol tablet. And I would like to thank you, and the implementing partners are Government of Nepal. Other partners are USAID, NFSP2, and partners, UNICEF, Care Nepal, Rural Health Development Program, Health Right International, Nepal Society of Obstetricians and Gynecologists, and One Heart Worldwide has also implementing in one of the districts. Thank you very much.